Today we're going to cover the integration of care between behavioral health and primary care. And integrated care, I would say all of you already do in a broad sense, because you're coordinating care with other providers. And integrated care can be different depending on the stakeholder. For me, working as a behavioral health specialist in primary care, I have a set definition for what integrated care means. When I first started working in this program, again, different people came with different ideas of what that was. I had a PCP contacting me, get in touch with your psychiatrist to find out what I need to prescribe for this patient. And it couldn't flow that way because the psychiatrist wasn't treating that patient. Or I had a clinician at behavioral health who was working with a patient that didn't want to go into detox but wanted to abstain from using alcohol. And that behavioral health specialist tried to, I guess, expedite the process in getting that patient into rural health and having the PCP prescribe a benzo. And I can't get involved with that either because the PCP isn't there to try to help this person detox at home. So we need to have an understanding of what my role is, and that has evolved into what we have today, which is that I'm embedded in primary care, working with the PCPs who are referring their patients that need mental health intervention. We're going to cover the levels of integrated care, and that ranges from coordinated care to, once again, what I do, which is the embedded care in primary care. And the reasons for integrating. PCPs can't do it all, but that's what your patients come to you for. They're comfortable with you, and they're looking to you for the answers. And how do you cover behavioral health in your 15-minute medical appointment? And that's where integrated care becomes a valuable resource for you, hopefully. Lastly, I will focus on the program that has been developed between the agency I actually work for, which is Community Services Board, and with Eastern Shore Rural Health. And I'll give you examples of course, the success stories on how that has worked. And this program has been 6 years in the making. So with integrated care, we're primarily focused on mental health, substance use, and primary care. The webinars I really like to go to for information for me come through the Center for Integrated Health Solutions. And this is funded by the Substance Abuse and Mental Health Services Administration, as well as the Health Resources and Service Administration. The role of that program is to promote the development of integrated primary and behavioral health services to better address the needs of individuals with mental health and substance abuse conditions. And again, I think more and more as mental health needs become apparent, it's the PCPs that the patients are going to for that help, and PCPs are looking for resources on how to provide that. So we have a coordinated system that provides medical and behavioral health services to address the whole person. And healthcare providers collaborate to coordinate the assessment, treatment, and follow-up of health conditions. That's it in a nutshell, which looks good, but what does it mean really? So we have different levels. In the coordinated care, two different systems are trying to navigate, how do you get your patient into a mental health provider? How does the mental health provider get their client in to be seen by a PCP? Navigating these systems that are foreign to each entity can be frustrating and time consuming, and you're playing phone tag, or you're getting the referral but not all the information that you need, and that kind of breeds the them versus us mentality. One of the ways to help combat that is to go to the co-location of care, where you have either primary care, a primary care provider in a mental health setting, or you have a behavioral health specialist in the primary care. They're not using the same treatment systems. They're not using the same electronic records, but they're located in the same building. It makes it easier for the patient. They're going to the same place for both services, but it doesn't necessarily make it easier for coordinating care. I've worked in such a service, and yes, it was better that we were housed in one location and we would have weekly staff meetings, but I could easily go a day of seeing clients and never see anyone else who is providing services in that same building. So it doesn't necessarily lend itself to more access to other providers. And then you have what I deem to be true integrated care. You're in the same location, a team approach using one treatment plan, and that is what I actually do in the primary care setting. I'm using the electronic health record for the patient at the rural health setting, so they are not a client at the Community Services Board, they're a patient at rural health who's getting integrated care. This is really another way of stating that same information. Again, you have this continuum of care that ranges from coordinating different locations to co-location, and finally to the joint system of integrated care using the same system, the same treatment plan. Rural health is increasing their screening for patients with depression. They're using the PHQ-2, to see if somebody is positive for symptoms of depression. So when you're increasing the screening, and there's a push for that across the board, what do you do with that patient when they are positive for depression? Where do you send them? Do you refer them on to an agency that may have a waiting list of a month or 6 weeks? And that's where I think integrated care steps in and helps to fill that void. Plus, you've only got 15 minutes with the patient, and now they're positive for depression, but they came in for a sore throat. Again, where's your resource to help get care for them? The behavioral health specialist provides services in the primary care setting, which, as I've pointed out, is what I do. There are services in which a PCP is in with the behavioral health setting, and you'll see that mostly with situations where a person's being treated for serious mental illness and substance abuse. Those I am not as familiar with. That won't be the focus for today, but there may be some of you that are providing that role in the behavioral health setting. In terms of the differences in culture, for myself, I can tell you that in a traditional counseling setting, you have your counseling session that is supposed to be sacred and uninterrupted. When you're at a primary care setting, there's a knock at the door, there's the instant message when you're in with a patient that someone else is waiting who may be in crisis, can you work them in? And you'll get a warm handoff. I see that your next patient has canceled, and I've got someone in my office who's crying, can you walk over and meet that person? So there is definitely a cultural difference. You need to be flexible. You need to be ready to take on what your day is scheduled, but also what's coming down the pipe for you. In terms of the lack of understanding, so as a PCP, you may have a patient that needs medication. but it's 6 weeks to see the psychiatrist. How can that be? This person needs to be seen now. And so it's trying to help educate on what the process is. Again, I'm referring to CSB, the Community Services Board, because that's where I work. And there may be a lack of understanding for the intake process, being that the person has to get the intake scheduled, meet with the psychotherapist for the 2-hour formal assessment and diagnosis, and from there the referral gets made to the psychiatrist. And that's a different process than referring directly to a psychiatrist in primary care. But as in most communities, we just don't have a lot of availability in terms of that resource. And I'm going to look at, as a whole, what the reasons are for integrating care. I think as primary care providers, you maybe have the same, but much longer list for those reasons. The average life expectancy for a person with serious mental illness is decreased by 25 years.
Wow.
Yeah, huge. Largely due to treatable medical conditions such as heart disease and diabetes. Part of my role as a behavioral health specialist is to talk with a person about their self-care management. You know, when you're depressed, you don't feel like getting out of bed. You don't feel like paying attention to your nutrition. You may be having cravings for processed carbohydrates. Well, now your diabetes is out of control. Or you're diving into the bag of potato chips and not paying attention to your salt intake and again, how you're managing care. You just know you're depressed and, yes?
I'm assuming that's untreated,
The life expectancy?
If it's untreated, it's decreased by 25 years?
It's a good question in terms of that particular resource. I don't know. I've got another resource on the last page who gives the same statistic. So
That's a big chunk.
it is. It's huge. Well, they're also more likely to be smoking. They're more likely to not be getting adequate dental care. So yeah, there's a lot of lack of care involved with that. One of the benefits of integrating the services is reducing over-medicating. And I will have doctors that will come to me and question, what's the psychiatrist prescribing? I know what the patient is telling me, but they're asking for X, Y, and Z, and I don't have the latest update. And being an employee of CSB, I can look and see that there's a signed release of information, and I can find out at that moment what the medication is so that there isn't a duplication. Primary care providers provide 50% of all mental health care. You're known to the patient. You're the person they want to go to. And when I've had several situations where the physician has talked to the patient about going and getting counseling. I'm not going there. I'm not crazy. Crazy people go to that place. And they won't go. There won't be a follow-through. If I'm there, you know what, we have a counselor who's here today. Why don't we bring her over and introduce you and, just meet and talk for a few minutes, and then we can do the handoff. The guard comes down. That I can either meet with them in the exam room, or they can come over and talk with me in the office that I'm working in that day. So they are more likely to follow through when I become a known. When I'm not a known, I'm just that person that's in that building somewhere else in the area, they're not likely to come. Again, the higher rates of mortality. And I think about These are loved ones. You know, this is somebody's brother, this is somebody's mother, somebody's whatever. These are loved ones, and they need the help. Fragmented healthcare systems result in unmet healthcare needs. Maybe there's somebody in the mental health clinic that is complaining of insomnia, and so that person is trying to tackle it from a mental health perspective. But as it turns out, there's a medical condition that's interfering with sleep. Or maybe it's the other way around. The patient is in with the PCP talking about insomnia, but it's because of a mental health condition. So with the integrated care, you get those systems together. And I am finding that more and more, I'm getting referrals for patients with insomnia, because now the PCP has a resource. When a person is coming to them, they're not sleeping at night, their diet is out of whack, their energy is out of whack, they aren't exercising during the day. It just is a snowball effect. The only resource available for the PCP is to prescribe. They want to help this person get back on track as quickly as possible and get their other medical conditions under control. With an added resource, such as myself, I can talk to the patient and find out what are maybe some other variables involved with inadequate sleep. What are they stressed about? What happens when they go to bed? What is their nighttime sleep ritual or pattern? Are they sleeping during the day? If somebody's taking, they'll tell me I'm taking a nap for how long, 2 or 3 hours. Well, that's just plain old sleep. So when you go to bed at night, you're not tired. Or they'll go to bed at 8 o'clock and eat in bed and watch TV and think, well, at 11 o'clock I'll fall asleep. And they don't understand how those behaviors are interfering with their bed being conducive for sleep. I have the time that I can talk to the patient about that. Or if there is something that's causing them great anxiety, I can talk with them about relaxation techniques that they can use at night. I had a gentleman that, I've had several cases like this, but he stands out. He, high anxiety, I'd met with 2 of his siblings, also high anxiety. So I talked with him about what is a safe place for you, what's a calm place for you. And there was somewhere that he liked to go and just sit, and he didn't have the racing thoughts. I said, okay, when you go to bed at night, I want you to think about that place. You've been there, you've experienced, you know what it looks like, you know what it smells like, you know what that breeze is like. Put all of those details into place when you're laying in bed. So now he's focused on this calm experience rather than his thoughts racing about the thing that's causing him great anxiety, which was job loss. And he was working on getting another job, but obviously he's not going to fix that at night when he goes to bed. And it was indeed throwing everything off, and he wasn't caring about his diet for managing his diabetes. So he used this technique, and it worked for him, and he had more energy, and he had a better outlook, and he invested more energy into finding a job, which he did. So, yeah, as I say, I'm going to point out these good cases that do turn out. It doesn't work for everybody, and sometimes they do need medication to help get them back on track. But it's good when we can work in concert to figure this out. And again, PCPs, that's where they're going to go. They know you. They trust you. Everybody goes to the doctor. So it's familiar. There isn't the stigma and taboo that comes from, why don't you go see a mental health counselor? And again, it's the I'm not crazy. So for the number 5, I call those the frequent flyers. And everybody has them. Everybody has that person that they're on my schedule again, they're on my schedule again. So when you have another resource available to you, such as a behavioral health specialist, okay, let's get this person in with Susan and see if we can figure out other avenues to take to help reduce the number of visits required. I met with a patient that had, in quick succession, gone to the emergency room 4 times by ambulance for panic attacks. And of course, the hospital kept referring the patient back to the primary care provider, and it just was not breaking the cycle. So I got involved with that person, met with them a few times. They agreed to be referred for longer-term counseling, which also got them access to seeing the psychiatrist. In the meantime, while waiting to get them in with the longer-term counseling, I could also provide them with stress management techniques to use when they were starting to feel the onset of the panic attack. Since they've already been to the ER 4 times and been seeing their PCP, the medical issue was ruled out. So it's fair to say that you're not having a heart attack. I'm sure that's what it feels like. Let's talk about what you can do in those early stages when you're starting to feel that come on. Cost. I mean, for all of us, whether it's our personal finances or we're talking about the system at large, reducing costs is a motivator for figuring out what's the best care we can provide to lower these expenses. And integrated care is one of those situations. Again, we've got somebody going to the emergency room repeatedly for panic attacks. Let's get them in with the mental health professional and figure out what's the driving force behind that. Integrated care is not new. This has been going on for over 20 years. The VA has certainly been using integrated care and telepsychiatry. But I think because of more coverage in the media about the need for mental health resources and the fact that we do need to reduce costs, it's getting more momentum to get the integrated care into primary care. So Partners for Health, this is the program that I'm involved with. It's the partnership between the local community services board and the Eastern Shore Rural Health, which is the primary care setting. And I'm working in the primary care setting. That's what I'm going to focus on is embedding a mental health specialist into the medical facility. So I refer to myself as a Prius because I'm a hybrid position. I work for Community Services Board, but I'm in the Eastern Shore Rural Health. I'm integrated in that program. Excuse me, I use their electronic health record system. I work under the diagnosis that's been given by the PCP. I'm not doing a formal intake assessment like I would at Community Services Board. So for that reason, that's why I call myself the hybrid. I wear 2 hats. I'll explain this more later, but even in terms of being located on the Eastern Shore, it's a unique landscape, and people are often referred to as either from here's or come here's. And so I can also be called a hybrid because I'm some of both. I wasn't technically born there, and like the rest of my siblings, I came in under the cloak of night and got passed off as being from here. But certainly raised there, and I knew the culture, and I left for a long time. and recently came back. So I seem to be safe for people who are either from here's or come here's. The eastern shore of Virginia is located just south of the Maryland eastern shore. We are in between the Chesapeake Bay and the Atlantic Ocean. Some people may have become aware of us more recently because of the rocket launches that have been coming out of NASA at the NASA facility. And you know, it could be that you live in one of these areas where you're actually able to view those rocket launches. So the Eastern Shore is broken down into 2 counties. On the left, you have the facilities for the Eastern Shore Community Services Board. So these are our mental health facilities interspersed with the Eastern Shore Rural Health primary care settings. If we have somebody, if you can see the Bayview Clinic is loaded, that is the most southern location for the Eastern Shore Rural Health Center. And let's say the primary care physician has referred a person with mental health needs to go to the mental health outpatient counseling offered by the Community Services Board, because if you go there, regardless of income or health insurance, you'll be seen. They'll work with the person on a sliding scale fee. Well, that facility is located here. So the patient now has to get all the way from this area to the northern end. They're not likely to go. They have to be highly, highly motivated to go. In terms of public transportation, it's almost non-existent. There is some, but it isn't even easy to get to. The stops that are provided, it still can be a hardship for a person to get to the bus stop to get all the way to the other end. So I don't actually go to this facility, but I go to this one, which makes it much easier. And they're used to the rural healthcare setting and system. They will go to the next center and check in just as if they were going to their own. So they are more likely to come to see me in that setting. Recently, CSB and Rural Health partnered for offsetting the difficulties with the transportation. So for a patient in need who needs to get to Eastern Shore Rural Health, whether it's to see me or a medical provider, they can contact the Community Services Board, who will set it up through their transportation system to get that patient to the community health center. So the integrated care isn't just on site using me. They are trying to come together in many ways to make this beneficial for the patient care. Because again, if they can utilize the office services, the goal is to keep them out of the emergency department. So this is how Virginia's Eastern Shore is connected to the rest of Virginia. You have to go across the Chesapeake Bay Bridge Tunnel, and that includes paying a hefty toll. I forget what we are now, $15 one way. Right. So we actually still have residents on the Eastern Shore of Virginia who've never left. They don't have the transportation, and they certainly don't have the funding to make that trip, and it's foreign to them. It's too big, and for somebody with panic disorder, you're not going to go across this. That's a tunnel, and that's a tunnel. And then inside that tunnel, it's 2 lanes, each going in opposite directions. So at any rate, they're going to try not to go. They may go up into the Eastern Shore of Maryland. This becomes important for having to get somebody to an inpatient psych facility, and it can only be done in Virginia. Even if Maryland may be the most convenient to access geographically, it's mandated that that person has to receive care in the state of Virginia. So this is where we have to get them across. This is just some more information about the Eastern Shore of Virginia and how we're laid out, as well as the services provided at the Community Services Board and the Eastern Shore of Rural Health. I say on a good day when everybody's home, we might get up to 50,000 residents, but at any rate, rural health sees about 80% of the residents on the Eastern Shore. So it's a huge undertaking. And what do they do when they are, again, getting so many patients with mental health challenges? And that is what sparked the need for integrating the primary and the behavioral health care. The Community Services Board has on staff 2 adult psychiatrists, and one of those is only part-time, and 1 child and adolescent psychiatrist. And aside from that, there are 2 private psychiatrists in the area. So it's a limited area in terms of resources available for the residents there. And it's certainly limited resources in terms of primary care, trying to access help with serving the needs of their patients who have mental health care issues. So this building is Community Services Board, which used to be the old Dollar General building. This is one of the rural health community health centers. $7 million building, pretty new. This is where people want to go. So this adds to, I think, I'm not going there. There versus there, this is what they know. This is where they're comfortable. This is where they feel like they're going to get seen quickly and get the best care. It may not necessarily meet their needs, but I think it adds to where they're more comfortable going. So the Partners for Health program was started in November of 2013. It had been previously grant funded, and through that grant, the mental health provider saw patients as rural health patients, but they were also dually enrolled as clients in the Community Services Board. So those notes had to be taken into electronic health record systems. She went to all 5 community health center sites and had an administrative assistant. So it was a start, and from that, the agencies figured out what they needed to better meet the needs of the patients. What came out of that was the grant ended and a new program evolved, the Partners for Health. So I'm the only behavioral health specialist that goes to the Eastern Shore Rural Health sites. I do that on Tuesdays, Wednesdays, Thursdays. And so at each of those 3 sites, I'm there 1 day a week. The remaining 2 sites can also refer patients, and they come to the closest community health center, the closest located to them. The other 2 days a week, I say I'm the bookends. I work on Mondays and Fridays at Community Services Board and provide the traditional mental health counseling there. Previous to that position, I was in emergency services. So that also helps me with having an understanding of how emergency custody orders and temporary detention orders work, what a client is going to experience if they go to the emergency room for mental health care assessment. because there have been occasions where a person is in crisis at rural health and I need to get them to the emergency room. And the more information a person has, the less fear they have about what they will encounter. So on average, I've seen about 250 patients per year in the rural healthcare setting. And that's in comparison to about 50 clients a year in the mental health care setting. So there's a vast difference. Certainly in the primary care setting, it's a faster pace. And again, you will get interrupted. You have to be able to triage. You have to be able to be flexible. I've become more of a known, which means people are becoming more comfortable with referring. Patients are becoming more comfortable with saying to their friends or their family members, you need to go and ask for a counseling appointment because here I think you have depression going on. So the good thing is we're accessing more patients. We are providing more services. The tough part is that the hours aren't increasing. So just as you all are having to do more in the same amount of time, we're having to figure that out as well. So to get to me, I typically get a referral from the primary care physician. They've had this person in their office, appear to be highly anxious or very depressed. Rural Health is now offering the PHQ-2 to screen for depression. So between the patient health questionnaire 2 and 9, those are instruments being used in referring patients to me for counseling. Those appointments are made either at checkout, when the person's done with their primary care visit, they go to the checkout station and the medical business assistant that's working there will put them on my schedule. I might get a referral through the electronic healthcare record system, so I'll call the patient myself, or I'll check that when I'm off site and I'll send a telephone encounter to one of the MBAs that I've been working with and said, please will you call this patient and get them on my schedule for the next available appointment. Again, I might be getting an instant message or a knock on the door. Can you see this patient? They're in my office now and they're very upset. So I also can get a patient referred to me through an immediate warm handoff. So there are a variety of ways in which patients will come to me at the primary care setting. I think the way our system is set up, it's an outlier. We do 1 to 3 traditional 1-hour counseling sessions with the patient in the rural healthcare setting. You'll find settings that a behavioral health specialist will offer a 20 to 30 minute appointment and focus more on the presenting issue when they went into the PCP, whereas I more broadly will pick up other factors that are involved, like recent death of a loved one, or there is a substance abuse issue. It's the way this program was set up. We tried experimenting with making those half-hour appointments, and they just don't work with this clientele. When they come in to see me, for the most part, with rare exception, they're ready to talk. And they need that hour, and it's amazing what can get accomplished in that hour. I only generate notes in the electronic health record system for rural health. So again, they remain patients there. They don't automatically become clients at the Community Services Board. And I will make referrals as needed. Frequently, they're going to go to the mental health outpatient services at Community Services Board. I've had some patients with private insurance, and because of their location, they would rather go somewhere else. So I have my cheat sheet of providers who are in the area, and I would give them that information. It's not that I only refer to CSB, but that is primarily where I refer. I know that service and I know what can be offered to the patient. Substance abuse treatment is on the Eastern Shore. Those services are primarily at the Community Services Board. And I've had situations where a person came in and again presented with insomnia, and as it turns out, they're drinking 2 or 3 or more glasses of wine at night, thinking that's going to help them sleep, and they don't realize how much that's disrupting their sleep. And then they're napping during the day, or it's beer. And I did have a patient, middle-aged, and she thought that a glass of wine, okay, maybe 2, and then by our second or third session, she was saying, I have a problem with alcohol. I'm actually drinking about a bottle a night. And we immediately got her in. I called the substance abuse clinician, who I knew was very passionate about her job, and got her in immediately. So it didn't have to go through the formal referral setup between Rural Health and Community Services Board. And I don't know exactly what that looks like, but through phone calls, we got her in that day. Also in a situation of the primary care provider who had a patient that left rehab early, and it was a situation that was alarming to the patient, what she was seeing, but she knew she needed the help. I had an opening that day through a cancellation, so she went right from that very day from rehab to her PCP to me, and then with the outpatient substance abuse clinician, so that she maintained getting the care that she needed. I have had a few situations where a person has been in acute crisis and not grounded, thought that she was seeing her deceased sister. Deceased sister was after her. Fortunately, the patient's daughter was there, and I was able to talk to the two of them together about going to the emergency room for further evaluation. And that patient did end up getting a TDO to an inpatient facility where she was kept for 10 days, and upon discharge came immediately to her PCP for continuation of medication. Because she couldn't get in, she only had enough medication at the time of discharge to get her through a few days, and the psychiatrist appointment wasn't for another 10 days. So what was she going to do? There was a problem getting the discharge notes transferred, so again, I facilitated with contacting the inpatient facility, getting the discharge records, providing those to the PCP, who then wrote prescription for enough medication until that patient could be seen at CSB by the psychiatrist, and she's continuing to maintain care there. So the system, it works. It may not be perfect, we're still tweaking it, but I think it's better than when you just had 2 separate organizations who maybe communicated through fax or phone tag. Now with this program, there's no charge to the patient, so that certainly also helps with getting them to see me. Because one of the barriers may be when they tell the PCP, I can't go, I can't afford it, I don't have any money. Well, the beauty of this program is there's no cost to you. And obviously that takes away the financial barrier. I only see patients 18 and older. And I honestly don't know exactly why that was put into place, because this was set up before I got hired at CSB, but I'm going to venture to guess, because I couldn't keep up with it, if we opened up the program to children and adolescents as well. I will help with the referral. I have had pediatricians that come to me and say, I have a 12-year-old or 10-year-old or whatever the age is, A little older adolescent I may meet with for one time to help them bridge the gap in between the services until they can get in. But I will absolutely help with that referral process and try to get them in more quickly. Self-care management, it's a big piece of what I do, and again, I think that medical providers just really don't have the time to look at what is the sleep hygiene, what factors into nutrition choices, what are the barriers to change for this person, and that's where my role is to come in and help tease that out. And figure out what is this person's motivation to change or not to change, and see if we can kind of lower those barriers. Again, this is the patient health questionnaire too. I'm going to pick on Joan Lingen since she got me into this, and say that her staff by far is gung-ho with this program. And I got one for you, Susan, I got one for you, Susan. We're gonna do the PHQ-9 on this one. And they do. And I have many a warm handoff. The system really works at that center. And I'm appreciative of that. I have custodial staff that will stop and ask me, how's your day going? Are your patients coming? I have a friend who comes here and I really think they need to talk to you. So, it's good to see that this program has gone from having very few referrals because people really didn't know me and weren't sure of the process, or maybe had gotten terribly frustrated with the process in the past. And we've been able to build those relationships, and they know what they can count on. They know what the service is that the patients will be getting. In some ways, maybe it works a little too well because I'm getting inundated with referrals, and can you work this person in sooner? And I will give up lunchtime, or if I'm at a health center where they have evening hours, I'll stay later. But I also have to be careful with that regarding my own mental health. This was one of your patients that came in and was reluctant to go to counseling, but we did establish a rapport and came to see me. And I've now been doing this for 3 years, and so I sometimes will see some of the same patients that I had seen in the past. Maybe they've got a different issue happening, or they've had an increase in whatever the problem was to begin with. And so the patient said to me, I've been smoking more. I said, well, why? Because it calms my nerves. And so as we continued to talk, I said, well, have you talked to your doctor about medication for your anxiety and depression? Oh, no. I said, well, why not? I don't like to take medication. I said, okay, but you know you're self-medicating. What are you talking about? Well, you're smoking more to calm your nerves. Is that really better for you than talking to your provider about taking medication to help with your nerves? Okay. So at any rate, she was placed on medication, and that helped her in the interim for getting the intake at Community Services Board and then the referral to the psychiatrist. Again, I think there's an advantage to having the time to being able to tease out what a person is going through and how they're responding in their personal life. I had a patient at one of the other health centers that recently came in for a complaint of pink eye, or the provider had the patient come in with the complaint of pink eye. And the way the system is set up, the PHQ-2 was generated, and she was scored positive for that, which triggered a referral to me. And I had an opening that day from a cancellation. So she'd seen the PCP at 9 o'clock, she saw me at 11 o'clock, and I was able to determine that she had severe major depression. She did the PHQ-9. She had a score of above 20. She had a lengthy history in her earlier years of trying to hang herself in her closet, and a few times her grandmother caught her, and another time her brother caught her. She'd never been to anybody for counseling. She wasn't raised by either parent. They both gave her up. They were late adolescents. You know, mother gave her to father, father gave her to his parents, and that's who raised her. And she still could not she just couldn't come to terms with her parents having given her up. The grandmother that raised her, she had a close relationship with, is now being seen by hospice. This patient and her 4 children live in the grandmother's home. So now you have an issue of, family of origin, grandmother who she's got this close relationship with is dying, and what's the housing situation going to be for her and her children? And you have the history of attempted suicide, and she came in for pink eye. So by the end of the day, the PCP was prescribing an antidepressant. We'd gotten her an intake scheduled within 2 weeks at Community Services Board, and she was going to come back and see me again before that appointment. So that's a day when the system worked so well. It worked the way you really want it to work. Now I can tell you that I'm one person and it's 5 centers. The director of integrated care at the Cherokee Health System, which is a model program located in the state of Tennessee. The recommendation there for a large health center would be a ratio of 4 providers to 1 behavioral health specialist. When starting out, the recommendation is at least 1 behavioral health specialist within a community health center, and that's full-time. So we're doing more with less. We're in a community where there's little access to resource, and you make the most of what you have. So I think we're doing that pretty well for being a small place.